Welcome to Med 1 Page. My name is Benjamin, and today I'm going to be doing Inguinal Hernias. So, hernia is a Latin word that means to protrude or to bud. So, a hernia is going to be defined as an abdominal protrusion of viscous or part of a viscous through a weak point in the body. And it's going to be associated with risk factors like smoking, chronic cough, constipation, obesity, heavy lifting, previous surgery, congenital pattern processus vaginalis, and then chronic blood outflow obstruction. So we have the relevant anatomy that we should know when it comes to the surgical approach to these inguinal hernias. So the first is that you have to know the inguinal canal is about 4 centimeters, and it has walls. And the walls are going to be looked at as the anterior wall, which is the one that is directly below the skin, the posterior wall, which would be directly below if you went through the skin and through the upper wall. Then the wall that separates the abdomen from the inguinal canal is going to be regarded as the roof, and then the floor is that is going to separate it from the structures below towards the feet. So the anterior wall is made by the external oblique aponeurosis. The posterior wall is made by the transversalis fascia and the conjoint tendon. And the conjoint tendon is going to come as a consequence of the fusion of the internal oblique and the transversus abdominis muscles. And this occurs as the muscles go on to fuse. As the muscles go on to fuse medially as they attach to the pubic tubercle. So that is going to be the conjoint tendon. Then the roof is going to be made by the internal oblique, which internal oblique begins around, which comes from around it's going to come from the inguinal ligament and move upwards towards the lower 8 ribs. So the roof is going to be made by internal oblique and the transversus abdominis muscle. And then the floor is going to be made by the inguinal ligament, and the continuation of the inguinal ligament that attaches to the pubic tubercle is the lacunar ligament. So to enter into the inguinal ligament, the structures that enter through the inguinal ligament are going to always do that through 2 rings. One is the deep ring, which is the opening to transversalis fascia, which is the innermost layer of the abdomen at that point. So in order to enter the inguinal canal, we're going to enter through the posterior wall through the deep ring, and that is going to be a U-shaped opening in the transversalis fascia. Then you will exit that inguinal canal after running obliquely, that is inframedially, through the superficial ring, and this one is the opening in the external oblique aponeurosis. And why this happens is that because during embryology, when the testicles are formed, they are formed in the abdomen. And as development occurs, they have to go out and get into the scrotum. So they will go through a deep ring, which is in the posterior wall, which is in the transversalis fascia, and come out through the superficial ring, which is in the anterior wall, that is formed that is formed by the external oblique aponeurosis. Then, as the testicles go through, they are connected by a spermatic cord from the outside to the inside, and this spermatic cord is going to be having certain structures that we're going to look at. It is going to be having certain coverings, and we shall also look at the contents of the inguinal canal. So when we look at some of the areas or the sites of hernias, we have the sites for the direct hernias, the site for the indirect hernias, and then you have the site for the femoral hernias. And these are joined together in an area known as the myopectineal orifice. So when you look at this region around here, where we have the inguinal triangle, which is bordered by the inferior epigastric arteries, which is laterally, the lateral border of the rectus abdominis, and then the inguinal ligament inferiorly. The triangle formed is the site where we have most of the direct inguinal hernias. Then, when you look around here, a few centimeters above the mid-inguinal point, a few centimeters, about 1.25 centimeters, we have the deep inguinal ring. And this one is the site where we have the indirect hernias. So if the viscous in the abdomen right below this is a transversalis, pass through that area around here to come out, that is the deep inguinal ring, we shall have an indirect hernia. Then we have the site of the femoral hernia around here. So we talked about this spermatic core, which is going to be connecting which is going to be transporting the blood supply, the nerve supply. It's going to contain lymphatics, all those that are going, the venous system that are going to the testicles. So it is covered by three coverings, and these are derived from the abdominal muscles and the order of which they are. So when you look at the abdominal muscles, the transversalis muscle is going to be the innermost, then it's going to be covered by the internal oblique. The internal oblique is going to be covered by the external oblique. So the same happens to the spermatic cord, except that now they develop new names. So the innermost covering is going to be the internal fascia, and it's going to be by the transversalis muscle. The middle layer is the cremasteric muscle, which helps in the lifting of the testicles, and this one is going to be in the middle, and it's derived from the internal oblique. Then the external fascia is going to come from the external oblique. So when you look at the contents of the cord, normally we have the first difference there. We have the testicular and the testicular arteries and the artery to the vas. We have the cremasteric artery. We have the pampiniform plexus, the lymphatics, the nerves, and the nerve here is the sympathetic branch of the genitofemoral nerve. We have the processus vaginalis, which normally is closed as the person develops. So if that processus vaginalis remains open for some reason, it is going to be a potential space within the cord through which this viscous this perforated viscous can continue down and find its way to the scrotum. So when you open the inguinal canal, there are some contents that you will see. When you open the external oblique, that is the anterior wall, the first thing you will see, of course, is the inguinal nerve. Then as you continue, you will see the cord, the spermatic cord in females, and the males it will be the round ligament. And then you will see other things like lymphatics, you will see blood vessels passing through there. And that is the inguinal nerve. So the nerves are the inguinal nerve and the genital branch of the genitofemoral. So we have the pathophysiology. What happens in indirect hernia? It is caused by mostly the at this point pattern processus vaginalis. And this sac oris, the processus vaginalis, is found lateral to the inferior epigastric vessels. So all indirect hernias are going to be lateral to the inferior epigastric vessels. And through the deep ring, the hernia is going to extend, and if it is long enough, it can reach the scrotum. Then we have the direct hernias, which come as a consequence of acquired weakness. And this can be due to risk factors like smoking, which interrupts collagen synthesis. It can be things like lifting heavy weights, because already the way the layers, the three part layers of the abdomen layer on each other, this is transversalis, the internal oblique and internal oblique, is not going to be very good at this one point. It's going to be the one point of weakness. So anything that, if there are other factors coming to play, that increase the intraabdominal pressure, it will be very easy for the viscera to herniate through this orifice. And we have the pantaloon hernia, which comes when we have a direct and an indirect hernia on the same side. So when you look at the clinical presentation, most of the time patients are going to come in with a groin swelling that is associated with pain or discomfort or heaviness. that comes and is worse on standing, because when you're standing and gravity is pushing everything down, the pressure in the lower abdomen is going to increase, and that most likely is going to cause the hernia to protrude. So most times when the patient is laying supine, actually the hernia may reduce and you may not be able to see it. So we come up with maneuvers that will help us to see it. Then we have the signs that you can elicit. We have the expansile coughing pulse, whereby you ask the patient to look away from you and cough. Looking away is just to prevent spread of infection from the patient to you. So you tell the patient to look away and cough, and you watch. If there is a hernia, there will be an impulse there or a swelling coming up. If it is not, sometimes you have to touch and feel if there is something that is coming up. Then we have we have a reducible swelling that is above and medial to the pubic tubercle. That's most likely when you have a direct hernia. It's the one that is closer to the pubic tubercle because of the position of the Hasselbeck triangle. It's closer to the pubic tubercle. Remember, its medial border is from the lateral border of the rectus abdominis. Then we can have the indirect hernia tracking to the scrotum, and the direct hernia is just broad-based and rarely scrotum. Then we have the techniques of examination. We have things like the internal ring occlusion, where you put a thumb. So when you're examining hernias, you have to use all 5 fingers, half the role they play. So the thumb is normally used in the internal ring occlusion test, where you place your thumb on the internal ring and ask the patient to cough. And if you see a swelling, and if the swelling is medial to your thumb, that is most likely a direct hernia. If you only see a swelling if you release the internal ring, then you're sure that is an indirect hernia. We have the ring invagination, where a finger is pushed through the scrotum and towards the superficial ring, and the patient has to cough, and you feel the impulse at the T-bend. Then the Zieman's test, that involves using the index, the middle, and then the ring finger. You have the cerebral zone. We have the silk sign. Then we also check for the abdominal wall tone, that is using where we use the head elevation or leg raising oval server to detect the amalgam badges. And if the amalgam badges, these are protrusions around the areas around the inguinal region. So if someone has them bilaterally, it shows that they have increased abdominal wall tone. Then we'll do the general examination, where we check the abdomen. We want to check the lungs, because chronic cough can lead to increased intragastric pressure all the time, intracranial pressure, sorry. Then we do urology. We do a rectal exam, because if someone has chronic urinary obstruction, they're going to always compensate by increasing their abdominal pressure. In the females, you have to check the labia for thickening. Then we have the complications of hernias, and this can be irreducibility, whereby the hernia is stuck outside and it cannot be pushed, or what we call reduced. Then you have obstruction, where the contents of the bowel, most likely the small bowel, are stuck within the sac of the hernia. They cannot move away, leading to obstruction or signs of obstruction. Then we have strangulation, whereby the trapped part has a compromised blood supply. And we have incarceration, whereby we have a hernia that is trapped, cannot be reduced, but still has an intact blood supply. So all incarcerated hernias are irreducible, or they are irreducible hernias, but not all irreducible hernias are incarcerated, because some reducible hernias may actually have a compromised blood supply. Then we can have things like testicular atrophy coming in due to the cord compression. Remember, the cord contains this testicular artery, and chronic compression of this may actually lead to things like that. So we have some hernias with special names. We have the Amiant hernia, which is hernia containing the appendix. We have the Lichtenstein hernia, which is hernia containing the mucous diverticulum. Richard's hernia, whereby the hernia is trapped, only part of it is trapped, most like the antimesenteric border, the one that is away from the blood vessels, is trapped. So we have around 3 loops forming a kind of a W, but the part in the middle is the one that is trapped and it's more prone to ischemia. Then we have the sliding hernia, whereby the sac wall is formed by a retroperitoneal organ. maybe the colon, maybe the bladder. So investigations we can do, the clinical diagnosis is the primary thing, and it's going to be supported, or we're going to rule out other things, maybe rule out other differentials. With ultrasound, we can do CT and MRI. Then we can try to rule out risk factors. For example, if you suspect they have set hyperplasia, you have to investigate that. Because if at all you do not, and you correct hernias, but your risk factors are still where the risk of recurrence is increased, then if you're going to do surgery, of course, you need to do the pre-workup or pre-operating workup. You want to evaluate your patient if they have strangulation. The management, surgery is always the definitive management, and it can be elective repair for symptomatic hernias, and if it is strangulated, it's going to be an emergency surgery. Then the conservative management can include things like truss, whereby belt-like appliances are applied to apply pressure at the point of exit of the hernia. But these are associated with very many problems like ischemia at the point or the pressure points along the pelvis. We can have increased risk of bleeding during surgery, and also because the non-solve problem, it still stands a high risk of someone getting the strangulation and things like that. Then we have taxis. Taxis is the manual reduction of the incarcerated hernia. So the patient is put in a supine position, the hips flex and the knees flex. Sometimes a muscle relaxant is used, and with a hip internally rotated, we try to reduce that hernia until that it goes back, and it's best within the first 6 hours. Most likely when the hernia is irreducible, within the first 6 hours, you can try to attempt. But before you do, you have to make sure there are no signs of strangulation, because if the blood supply is compromised and you continue to reduce forcefully, you may actually perforate. And then after 6 hours, it's not advised to do so because still the risk of perforation is high. Then you have the techniques that are used in repair. So for the indirect hernia, there is the high ligation, mostly did in peds. We have the Bassini repair, the Shouldice repair, and then you have the mesh repair, which is by the Lichtenstein repair. So in children, a mesh is not commonly used, but in adults, a tension frame mesh is preferred most of the time. When you use the mesh, use the Lichtenstein. When you use no mesh, you're using the Bassini or the Shouldice, and that can be even the modified Bassini. Then the direct hernias, still the Bassini is there, the Shouldice, the Lichtenstein, the IHAS. Still, you can go laparoscopic in both cases. And here the principle in direct hernias is to reinforce that posterior wall because there is a weakness that came in. So you want to reinforce that. So we have some of the complications that come from surgery, and those include things like recurrences, hematoma and seroma. We have infection, we have nerve injury, testicular atrophy, mesh complications like formation of the meshoma, which is a kind of hardening around the area of the mesh. And other things, they also increase risk of infection with mesh because this is foreign body. Then we have some rules that come in when we are examining hernia. These include always examine the opposite side, always do a parorectal exam, always examine the urethra, and always check for the abdominal wall tone. So finally, the last part of this video, we're going to look at how we can differentiate our direct and indirect hernias. So when it comes to indirect hernias, the indirect hernias are more common in the childhood, while the direct are more common in the elderly. The etiology is because in the indirect hernia, we have a pre-existing sac, that is the patent processus vaginalis, while in the direct hernia, the etiology is an acquired weakness in the wall. Then the pathway is going to be through the deep inguinal ring, whereas in the direct hernia, it's going to come through the posterior wall of the inguinal canal. That is in the transversalis. Then the shape and the direction. The shape of the indirect hernia is most of the time going to be oval or piriform, and oblique, which means it's moving inferomedially. while the direct hernia is just going to pass through the wall and expand and become globular all around. Squatted descent is only in the indirect hernia, the posterior hernia, where the descends down like that. The relation to the cord, the indirect hernia is anterolateral, while the direct is posterior. When you do the internal rig occlusion, the impulse can only be had if it is a direct hernia. In the indirect hernia, you will not feel any impulse because you have occluded the passage of that hernia. Then the invagination test, if you put the little finger through the scrotum and go to the and push it towards the superficial ring, the impulse at coughing is meant to be had on the tip of the little finger. But remember, you have the whole finger there. So if you feel it at the palp, the palmar surface, around the palmar surface, right behind your nail, that is the palp of the little finger, is going to be a direct hernia. We have the Zieman test, whereby if you feel the impulse on the index finger, it's a direct hernia because the index finger is placed on the deep ring. If you feel it on the middle finger, then you know that is going to be a direct hernia because the middle finger is placed on the Hasselbalch triangle. Then we have laterality. The indirect hernia is usually unilateral, but can be bilateral, but the acquired weakness is most times bilateral. That is for the direct hernia. And complications of suction and strangulation are more common in the indirect hernia compared to the direct hernia. Then during surgery, the sac of the indirect hernia is opened, but the sac in the indirect hernia is not necessarily opened. So we have come to the end of this video, and we have covered a lot about inguinal hernias. So if you find this video helpful, I'll be glad if you share it with a friend, or left a like and a comment. If you want anything clarified, I'll be glad to answer in the comment section. Thank you very much. My name is Benjamin, and have a nice day.